Very quickly about Migraine and Headache Australia. Our mission is really threefold. We aim to provide trustworthy, reliable, and information for you. That's what this Awareness Week is about, and bringing you the experts. We aim to fund research each year into a migraine or headache study or research, and we aim to fund Australian studies, and we advocate support for people living with headache and migraine disease as well. We've been talking about each of the sort of the key pieces of work, and happy to answer any questions that you might have about any of these items that we've been sort of involved in. But these have been highlighted throughout the week, and we'd encourage you to go back and watch some of the recordings, which are already up on the website. All the recordings are up. This is a world record for us in terms of getting the recordings available. So if you've missed any of them, they are all there for you, where we talk about each of these, as well as the topics that have been covered during the event week. So you are in the right place if you have migraine or headache, if you're a partner, parent, or caregiver, if you want to connect with others, or if you'd like to ask a question, particularly if you'd like to ask a question. That is what today is all about. We're trying to close the gaps and making sure any questions that slip through, we can try and pick up and answer. And if you do want to connect with others or continue the conversation, we'd encourage you to join our support group. We have around 4,500 members there. And it's a great place to connect with others like yourself, get ideas or bounce ideas off other people to help make decisions or get an idea about your situation. And of course, we are using Zoom webinar. So there are some tools that are available for you here, like the reactions, which are already being used. Thank you very much. And you can put your questions in. The questions, when you submit them through the Q&A, come straight through to us. They're not public to everyone. There is also the chat. And the chat is optional. You can minimize or close the chat, and you can reopen it without losing anything. So feel free to use that functionality as well. So quick introduction to myself. If by chance this is your first webinar from the week, if you haven't been able to catch the others, welcome. It's great to have you. We would encourage you, and we'll be talking about the webinars that you may have missed throughout the week. My name is Cincinnato. I'm the Director of Operations at Migraine and Headache Australia, and I am someone who lives with migraine and tries to advocate publicly to the government, to media, and through a number of different organizations and coalitions in Australia and internationally. I'm very passionate about helping people with migraine and headache. And we also have Anik. Now, Anik has been with us for several years. She does a lot of the writing, a lot of the content for the website, for newsletters, for emails. She's very talented in that area, and she's also our digital lead, and she's been our moderator for the week. And she's been behind the scenes the whole time. She hasn't had any of the credit, but today I would like to invite Anik to come onto the virtual podium to join me, and she's going to help me answer your questions and recap some of the highlights from the week. So welcome, Anik, and thanks for joining us.
Hi, Carl. Thanks for the welcome.
You've been here the whole time, but you've been in the chat only. So this is the first time people get to see you, which is fantastic. So it's been a big week. I'm going to hand over to you, and we can sort of run through some of the events that we held and talk about some of the highlights.
Yeah, so it's been a great week. It's good to see so many familiar names in the chat today. So on Monday, we had the new treatments webinar with Dr. Bronwyn Jenkins. And were there any particular highlights or things that stood out to you about that presentation, Carl? Yeah, what did you find the most interesting from Bronwyn's presentation?
Yeah, so she talked about the CGRP monoclonal antibodies. So these are the first treatments designed to prevent migraine that are actual medicines. So we've had medications before that have been used for migraine, like triptans, but that's for an acute medication. These are really the first that are designed to prevent migraine in the first place, and they target specific molecules. Many people in our community are familiar with the monoclonal antibodies, but she was able to share some of the real world evidence about how they work in practice. And when you have a doctor that can judiciously decide if their patient is going to be a good fit for the CGRPs, they actually find that when there is that sort of selection from the clinician, that the success rates can be even higher than what was studied in research. But the other thing that was also mentioned about CGRPs was some of the side effects. And we had, I remember a question that someone had asked from the audience at the time was that she was thinking about whether she was going to try the CGRPs because she just sort of looked online, some of the support groups, and she'd heard that like the feedback just seemed to be like there's so many different side effects and people weren't happy with them. And and Dr. Jenkins had a great response because she said that first of all, that's not what she sees in her practice. In her practice, it's very different. The other thing is that if you like, I know myself, if I was having a bad experience, well, let's say I was having a great experience from a new treatment and I got a new lease on life, I could go back to work, I was able to, re-engage with life. I'm not going to spend necessarily a whole lot of time in a support group or on groups talking about the treatment that I'm taking. I'm kind of just getting on with things. That would be my personal preference. But if I was struggling with the treatment, I'd be doing probably a bit of research online. I'd be reading about it. I'd be looking at forums. I might be saying, hey, yeah, actually, I was affected in this way too. So there's a little bit of a bias of information out there. It's not necessarily a balanced sample of people taking the treatment that we see in the support groups that are talking about side effects. So you just need to be careful a little bit with sort of the filter that you use. And that's why looking at studies and speaking to clinicians can be so helpful because you can get more of a sample of people who maybe aren't online or aren't on the support groups, which might be quite helpful. So that was one thing that really, or two things that really stood out from that talk. The other thing that I would mention about Dr. Jenkins' talk was the GPANs. So these are a new class of migraine acute treatment. So we just spoke about the antibodies, which are preventive. They stop migraine from happening. You take them every month or every quarter if you're taking the infusion version. But the GPANs are treatments that you take at the onset of a migraine attack. But the interesting thing about these GPANs that make them kind of a game changer is that they don't cause medication overuse. And they've been shown that the more you take them, actually, the better they work. So they kind of work like a prevention. It's almost like an all-in-one. So with triptans, you need to be careful because if you take too many triptans, it can cause medication overuse. If you're taking sort of 9+ triptans a month, then you're at risk of medication overuse if you do that for 3 months in a row. Now, it doesn't guarantee that you have medication overuse headache. And medication overuse headache, by the way, I should say, is a terrible name for it. Like all of the everyone I know is like it places blame on the patient. It's actually not the patient's fault. We're doing what we're told, taking medication when we have a migraine attack. But overuse of that medication can cause these rebounds and medication overuse. And that is something that just doesn't exist with the GPANs. And so to have a treatment that you can just take, at the first signs, or if you just want to be safe, or if you've got a wedding or a party or a board presentation or a meeting, a crucial meeting, like that can really put you at peace of mind. So the GPANs, one of them has been approved by the TGA in Australia. Both have been submitted to the PBS for their first round. They were knocked back by the PBS. But that's actually very common for a new treatment to be knocked back. There's a negotiation that goes back and forth. So that's really encouraging. That's very exciting. These are new treatments that are going to be arriving to Australia. There's 2 GPANs that are on their way. Anik, I know that you've written an article about these on our website as well, haven't you?
Yeah, the GPANs are very interesting and really exciting. The article that we have on them on our website just kind of details a lot of the things that Bronwyn talked about, but also shows kind of some of that data. So that's a place that you can go back to refer to any information about GPANs. But with the GPANs, and one thing that I thought was really interesting from Bronwyn's presentation that isn't necessarily included in the article is kind of her discussion of like that the things that she said about the timing with the PBS and the TGA approvals. I think that was something that was really interesting, and I noticed questions throughout the week as well where people were asking, why aren't they approved yet? Why aren't they in the stores yet? And I think Bronwyn did a good job of kind of answering those questions and assuring us that, we will see them at some point. It's taking a little bit more time. One thing that I just would like to say, I saw a question here from Jane in the chat about the CGRPs. And I noticed this a couple times in the chat throughout the week as well, with people concerned that the 100 milligram dose of Vyepti that's on the PBS is not as good as the 300 milligram dose, or it's not as good as the monthly injections of other CGRPs. And I just pulled up our article on Vyepti. There's a section there on efficacy, and in the clinical trial, it found that there was pretty similar efficacy between the 100 milligram and 300 milligram dose. I don't have a comparison here to the other CGRPs, but they're also on our website if anyone wants to check that out. But basically, the difference between the 100 milligram and the 300 milligram, there were 57.6% of people who had a 50% or more reduction in migraine days on the 100 milligram dose, and then versus 61.4% of people on the 300 milligram dose. So that's really only a 4% difference. So I hope that answers your question, Jane, about the efficacy of Vyepti with the lower dose.
Great.
And anyone else was wondering.
And we just showed that article there that was medically reviewed as well. So that's a great resource for people if they want to. You can type in Vyepti into our website and you can find that article, or you can navigate there from the menu on migraine and then through treatments and then find it. So that's fantastic.
Yeah. So should we go on to discuss day 2?
Sounds good.
To answer that question. So day 2 with Jacinta Johnson on triptans without a prescription. What did we cover off and learn in that session, Carl?
So triptans have been typically only available via a prescription from a doctor. So you have to see the doctor before you can try a triptan. And interestingly, triptans have been available over the counter elsewhere in the world for some time now. And now they've been downscheduled, which is a fancy way of saying that you don't need a script. And but they're not downscheduling the same dose level and the same quantity. So it's a smaller pack size and it's a lower quantity of triptan. So if you get stuck in a bind, these can be really great, convenient option where if you're having an attack, you need to go and grab something. It's better than nothing. But if people are still using kind of the full dose and they need a larger sort of quantity to last them sort of for that period of time, they don't want to keep going back, then it may be good to know, but it may not necessarily change their plan. It just increases sort of accessibility and convenience. Yeah, good for emergency, as Alini just pointed out.
Yeah. And if also for people who might have, if their migraine is otherwise well managed and they might not be seeing a doctor regularly for triptan prescriptions anymore, and it's good for those breakthrough attacks for people whose migraine is otherwise well managed. Was there anything else that stood out about that presentation to you? I thought it was quite interesting learning about the duty of care from pharmacists and thinking about how a pharmacist can be a great tool in your migraine management in addition to your doctor or neurologist. Yeah,
it's a really good point. And it brings up sort of the broader topic about how we can utilize the pharmacy, the pharmacist within the pharmacy. And there's one thing I didn't kind of realize until a little bit later was that the staff members in a pharmacy are pharmacy assistants typically. And they're not necessarily, they receive some training, but they're not necessarily receiving the same extent of training and education, like university sort of degree, as a pharmacist does. And so, and when you're going to a pharmacy, you don't necessarily have to make an appointment. You don't have to, to speak to the pharmacist, right? You can request to speak to the pharmacist, tell them what you're taking, whether it's for migraine or anything else, and they should be able to give you an idea to some extent, right? They're not doctors, but they can give you an idea about if you should be sort of aware of any potential risks or contraindications if you're taking multiple sort of things at once. And that can apply to treatments. It can also apply to supplements and vitamins. And there are some supplements and vitamins that are commonly used in migraine that can be really problematic if you're trying to have a baby or a child. So it is worth utilizing the pharmacy resource, particularly given that it's free in almost every case, and just making sure that you're sense checking kind of what your treatment sort of program looks like in the treatments that you are taking, particularly if you haven't had that conversation with your doctor. I mean, we should be telling our doctor everything that we're taking, so that they know if there's any sort of anything that's going to cause problems. But certainly, the pharmacy could be a nice little tactical way of getting that extra sort of sounding board for what we're taking, what we're doing.
Yeah, no, definitely very great tool to learn more about. Was there anything else that you wanted to discuss from Justina's presentation, or did you want to move on to
I'm happy to move
headache
on, and
research?
if people have questions, we can about that particular talk. I'm happy to go back to that topic.
Okay, perfect. So on Wednesday we had Dr. Hugdust. I'm
Yeah.
not great at pronouncing that one. Talking about new research into headache disorders. What parts of that presentation do you want to highlight today?
So I think first of all, I don't think Dr. Hoodus would mind me saying that he has the best hair that we had all week, with the big afro and the logo with that afro with the big head pain. He's a wonderful advocate and a great character and very softly spoken and just so lovely and nice. Um, and he spoke about research on headache disorders, and he also shared his personal story, which is pretty amazing. Coming from Iran to Australia, he's also the only full-time headache and migraine researcher that I'm aware of in Australia, which is pretty astounding and also super critical. Like we got to make sure that nothing happens to Dr. Hadous because we need him. Um, but he spoke about red flags. He spoke about primary and secondary headache and what those meant, and how if migraine is a secondary headache, which means if migraine has been caused by something else, like if you have meningitis, for example, you can have migraine, or if you've had if you've got another condition, like let's say it's like a tumor or something like that, that's causing sort of migraine type headaches, then migraine can be secondary. And if migraine is secondary, it means that actually your focus of treatment is with the cause of the migraine. So it will be addressing, the meningitis. It'll be addressing the tumor. And
Mm,
migraine is a symptom. And so in addressing that cause, the symptoms should resolve. When migraine is the primary headache disorder, then migraine is the condition that you want to be sort of treating and managing, and that is the case for the vast majority of us. Most migraine is primary. The vast majority of migraine is primary. But when there are certain conditions that he highlighted, particularly if it's late onset, if it's if there's been sort of dramatic changes, or you've never had migraine in your life and you're in your 50s, then it's worth getting sort of a check. Maybe you get an MRI, a scan, just to make sure that you take the right precautions, and you rule out any sort of secondary migraine by doing that. So I thought that was quite
mm.
interesting and one of the highlights for me.
Yeah, no, that was definitely very interesting. I also liked that Dr. Hadus drew attention to the ICHD in general, and like seeing that list of, the plethora of ways that people can experience migraine. I thought that was something that, I have spoken to people, and we've heard from people who've kind of said, my doctor doesn't think that it's migraine. They just sent me home with some Panadol and said it's a sinus headache or something like that. And so talking about the ICHD and showing how, diverse migraine can be, the fact that, not everyone has a headache. There have been a few people in presentations this week talking about silent migraine where they just have aura. And so I think, taking the ICHD, if your doctor maybe doesn't quite understand yet, that's a good tool that you could maybe take to your your clinician to discuss that further with them and kind of say like, look at this, you
Yeah.
need to understand.
Yeah, so we just had a comment from Jane saying that we should watch the comedy that Dr. Hadous has done recently. So he actually has done some stand-up comedy, and I haven't seen it yet because it was only sort of posted this week, and it's been a busy week for us. But I'm really looking forward to watching it. But it's pretty incredible. And he actually talked about like migraine and headache during the comedy, and I don't think it's done in sort of a derogatory. It's done in a very constructive way. But this is something that he works in, his full-time sort of work, and he has some interesting insights that for a bit of comic relief that might be insider jokes for us. So I'd encourage people to check it out. Let him know what you think. The other thing, Anika, that you mentioned was the ICHD. That's a pretty hefty acronym. Can you tell us? I want to put you on the spot. Can you tell us what that stands for?
It's the International Classification of Headache Disorders, I think.
Yes,
I hope
yes.
I got that right.
Yeah, it is. And what is it
Yeah.
essentially? Like, what does that mean?
So it's a directory, almost like a glossary of headache disorders, I guess,
Yeah.
created by the International Headache Society. And so it categorizes all the different headache types into, primary headaches, like Carl was talking about, and the secondary ones. Every basically known cause of headache currently that researchers have discovered. And it's a pretty interesting tool to look at if you're curious about learning more.
Yeah. There's
And
actually
it's
like,
open access as well. It's not behind some paywall, just to clarify that, because I know some people are concerned about not being able to access journals sometimes.
yeah. Should we answer a couple of questions before we go on to the next talk? There's a
Yeah, sure.
there's a few questions in the Q&A that I can see. So one is from Lynn about a treatment for trigeminal neuralgia. And trigeminal neuralgia is a facial pain. It can be excruciating, but it's quite distinct from migraine. The symptoms are different, the causes are different. It's often got to do with like nerves in the trigeminal area, which is linked with migraine, but very different to migraine. So the treatments for trigeminal neuralgia do not typically overlap. Like you're not, for example, using a CGRP monoclonal antibody. There may be some overlap in pain management treatments, but they are separate, if that helps. And if you're sort of looking for sort of good options for trigeminal neuralgia, I would say message us at info@thebrainfoundation.org.au, and we can point you in the right direction, Lynn. The next question was from Barbara, who said that she thought that migraines were caused by stress. And is there any information on why we sometimes wake up with a migraine? Anik, do you want me to try and answer that, or do you want to respond to that one?
Yeah, so in terms of the causes and migraines being caused by stress is one of the most commonly reported migraine triggers. We have had a couple of webinars in the past focusing on migraine triggers, and yeah, that's something that a lot of people do experience. But there's also everyone has different migraine triggers, basically. So for some people, it's bright lights or a hot day, dehydration, different types of food or alcohol, disrupted sleep. These things can all be migraine triggers depending on the person. So yes, you are correct that migraines are caused by stress, but it's not just that, I guess. But Carl, I'm not entirely sure on why sometimes people wake up with a migraine. Do you have any insight onto that?
Yeah, there's a couple of reasons why you can wake up with migraine. It can be, and these are not ranked in order of likelihood, but one example is the medication wears out. So you take medication, you have a migraine during the day, the migraine is still there in the background, and as the medication wears off and you go to sleep, the migraine can pick back up. That's one reason why. Another could be poor sleep habits, or not getting enough sleep, and your body having a migraine attack because it's not reacting well to the kind of sleep routine that you have. You could have a sleep disorder. So sleep apnea with migraine is really common. Insomnia is less common, but still higher in the migraine population than the general population. You could be having issues with caffeine. Having a high caffeine intake could be causing problems, and you could be having a withdrawal of caffeine that sort of wears out whilst you're sleeping if you're having coffee or caffeine during the day. Sleep is definitely a factor. Clenching or grinding your teeth is another one. There's dietary factors. That could be low blood sugar levels if you're eating throughout the day and your blood sugar levels drop. Dehydration, alcohol, hormones can be playing a role. There is a type of headache called hypnic headache. It is rare, but it begins in your sort of like it typically begins in the 40s and 50s, and that occurs pretty reliably between 1 and 3 a.m. and ends and sort of starts and finishes within sort of 30 to 60 minutes. But it can last up to 6 hours. But that's sort of a very specific type. It's the nickname's like alarm clock headache because it becomes so regular. Um,
Mm.
and then there's some other things like, there's a positional headache, which is intracranial hypotension, HYPO tension. That's a
Mm.
potential where your headache is moderated by the position that you're in. So lying down can sort of trigger it. But those are some ideas that or some reasons why you may be waking up with a migraine. What I would say is that if you are waking up with a migraine, you need a treatment that can act really fast because obviously, by the time you wake up, it's entrenched, and so you haven't had time to sort of treat early. So taking oral medication, if you've already got sort of nausea and that gastroparesis in the gut that sort of can cause the absorption to really slow down and to grind to a halt, um, is not going to be as effective as taking, for example, an injection of a triptan or a patch of a treatment or a nasal spray delivery. So I would look at alternative routes of administration to get a speedy result, and look at some of those factors that I mentioned about why you might be waking up. I hope that helps.
Yeah. No, that was a very comprehensive answer. Hopefully that answered that question. One question, pretty simple, from Marianne, has asked about accessing the recordings. So if you weren't here at the very beginning of the webinar, yes, you can access the recordings. They're actually already all uploaded on our website. So if you go to the event page, you'll be able to access them there.
Okay. All right, let's jump to the next topic that we had.
Yeah, so that was yesterday morning. We had the concussion interview between Brett Carney, who's a retired NRL star, also known as BK, and between Dr. Rowena Mobbs, who's one of Australia's leading concussion and CTE researchers. So they had a very interesting discussion. Carl, do you want to highlight some of the things that they talked about?
Yeah, this is very topical because there was a a Senate inquiry into concussion from sports. Now, concussion can come from accidents, car accidents. It's not just sport; it can come from domestic violence. There's lots of ways that we can be, sustain a head injury, and that was recognized by the Senate report. The Senate report's 187 pages. I'm making my way through it at the moment. I haven't finished it, but it is fantastic and very topical because it was released this week. And so to have this interview with BK and Dr. Mobbs is just fantastic. And Dr. Mobbs is Australia's leading expert and authority on concussion. She's a subspecialist neurologist that focuses on this area and sort of lives and breathes concussion, CTE, and its linked with dementia sort of all day, every day. So it was a real privilege to be able to hear from her and her insights. And one of the things that really stood out to me as a parent, and I know that there are lots of parents on that during that session who have kids that are playing sport or who have sustained head injuries, is the fear of CTE. And what she clarified is that there's almost like never been a case of CTE in children, in teenagers, and it's the type of thing that sort of starts to emerge from like 40s, 50s, and 60s. It's not something that you see, in young children or even in young adults for that matter. Having said that, the damage can occur, when you are that age. And Dr. Mobbs pointed out that it's sort of like in the American football where they've done this research, it's around sort of the college age where they start to get really sort of strong athletic builds. They've got these helmets, but and she mentioned how these helmets sometimes can make matters worse, which was kind of counterintuitive. But it was at that age where like the sort of real concussions and head injuries became quite prominent, and sort of incidents were being sort of were occurring. It's worth mentioning like why she said someone wearing a helmet could possibly be worse for concussions. So first of all, like what happens with a concussion, and you can be concussed from whiplash in the car. So what happens is the head moves really quickly back and forth, and the brain is floating in liquid in our skull, in cerebral spinal fluid. So it's kind of, if you think about it, sort of floating there. And so when the brain moves far, like when the head moves fast back and forward, it's kind of like holding a glass with like, an object in it that's going to bang against the edges of the glass as you sort of move it back and forth. And that's what causes a concussion. It's that impact. So whilst a helmet on the outside protects you from like that sort of injury to the surface of the skull, and potentially from worse injuries, that internal movement is still occurring in the brain itself, which is what causes a concussion. So unfortunately, ice hockey, they wear these helmets, and the NFL in the US, they wear these helmets. In Australia, we have these soft helmets, like in AFL, in NRL, in rugby union. They help the outside, but they don't necessarily protect the inside from that sort of concussion and from that movement. And
Mm,
so what she pointed out that was so interesting was that when you have these, these athletes, these college level athletes, that feel like they have this level of protection because they're wearing a helmet, they go in harder
mm,
into these engagements, these physical tackles with other players. They feel
mm,
because they have that protection. The helmet also reduces their sort of spatial awareness. So they don't necessarily have the same hearing as someone without a helmet. They don't have the same visual sort of perception because their vision's sort of narrowed down by the helmet as well. And so
yeah.
they're not as likely to see someone or hear someone coming from behind. So in those respects, she mentioned that helmets can be sometimes detrimental despite sort of the good intentions behind them. Um, so that for me was like, that was the first time I kind of heard that. That was pretty amazing to hear that, and in a very interesting perspective.
Mm. Yeah, definitely. Um, yeah, I also think it was great to hear from about BK's experience and kind of hear firsthand about, what's going through people's minds when they're wanting to continue playing despite having had a head injury because, you brush it off and think like, oh, it's fine, they need to be there for the team when in actual fact it's going to be better for the team for you to step aside and take some time off to recover fully, rather than continuing to play when you're seeing stars and can't think straight. So I thought that was an interesting part of the discussion as well.
Yeah.
Yeah.
Just to add on that, so yeah, so for me so I play sport, I play soccer. And
Mm,
so for me, like my takeaway was, and my kids haven't started sport yet, but they're too young. But when they do, the takeaway for me as a parent and as a player myself would be if you have a concussion or you suspect that you have a concussion, it's not worth it. And this
yeah.
is something that BK mentioned as well. It's like it's a short-term gain for for what you could be paying a very heavy price for. So it's
Mm,
it's it's about not getting back on the field when you are sort of dizzy and seeing stars and your balance is a bit warped. And then secondly, giving yourself a good amount of time to recover, at like 2 weeks to recover from when you've had a concussion. And
mm,
a concussion can't necessarily be diagnosed like with until 48 hours has passed. So sometimes it's very obvious that you've got symptoms. You sort of walk straight. You can't, you're seeing like four fingers instead of two. Like that's clear. That's a concussion, and that can be diagnosed on the pitch, on the field. But if you don't have any symptoms, you may think you're okay, but you may like vomit that night. You may have a really bad headache, or even migraine type symptoms, up to 48 hours after an attack. And that can be the concussion playing out as well. So you just need to be really careful. And if there's any suspicion of concussion, better to be safe than sorry and give yourself a generous recovery, at least 2 weeks before you go in. Because having a concussion, on day one and then having a concussion within that 2 week period, it's worse than the two concussions combined. It's like, it's not 1+1 = 2. It's 1+1 = 4 or equals 5 in terms of the damage to the brain whilst it's still
yeah,
recovering.
exactly. Yeah. Um, yeah. Should we discuss last night's
Yeah,
presentation,
the
the
panel.
migrant work panel?
Yeah.
Yeah. A fascinating discussion, and great to hear from everyone's personal experiences there, as well as Sarah's expert advice. Do you want to explain a bit about what we learnt in that session?
Yeah, so it was great to have Sarah, who's a solicitor that specializes in discrimination and workplace law. and legal rights and accommodations. And the panel were fantastic. We had 3 people working or living with migraine that had experienced sort of migraine in the workplace, and it was a really frank discussion. And there aren't necessarily silver bullet answers about whether you should or should not tell your employer about your migraine condition. A couple of the conversations that came up and sort of points of insight for me were that, first of all, we're not legally obliged to tell our workplace about migraine. If we are telling, like, if we do have a type of migraine that will likely have an impact on our work. Say, for example, we operate heavy machinery and we have a pretty severe form of migraine with aura, where we have the visual disruptions, and whether that's blindness or the scintillating scotoma that people with migraine with aura, like myself, have. Then you probably should disclose that you have migraine so that you're not putting anyone else at risk from a safety perspective. But if migraine doesn't if migraine's not likely to affect your ability to do the job, then there's absolutely no obligation. At the same time, the question came up. Sometimes work asks you about if you have any medical conditions. And I asked the solicitor, well, what right does a workplace have to ask you about a medical condition if it doesn't affect your work? And so she said that that's a really good question and it's a gray area. And so my takeaway from that was that if you have migraine, but it doesn't affect your ability to do your work, like the job, and you can perform the job adequately, then I don't think you need to disclose that you have migraine. Now, I know that that's not sort of straightforward, because if you have frequent migraines, it will interrupt your role or your work. But if you have that flexibility within the role if you're able to work from home or you're able to make up that time in unusual hours outside of the usual work day or week, then I think that that's fine. And hopefully you can have a workplace that understands that. We spoke about the advantages of telling work about migraine, as well as the disadvantages of telling work and the risks that are involved. And so I think it ultimately comes down to an individual decision that people make. And I think the people that were there for that panel left a lot more informed and a lot more confident about how they would go about doing that and whether or not they should tell or not. So it was the people that attended were very grateful for that session and just for the honesty and the insights from the solicitor and as well as from the panel themselves.
Yeah, definitely. I think one really valuable piece of advice as well, in terms of just the day-to-day management of migraine in the workplace, was the conversation about how to talk about triggers to your colleagues or your boss. There was one of the panelists, Megan, talking about how, if someone's a heavy smoker or they wear a really, really strong cologne or something, how kind of gently broaching that topic can be a good way to bring it up. And, there are ways to softly introduce it and kind of make them understand by saying, have you ever walked into a place and there's this overwhelming like barrage to your senses, that's what it's like when you live with migraine. And then having that kind of conversation about it can help introduce it without having people kind of respond saying, it's unreasonable, and giving them that empathy and helping them understand what it's like for you. I think that was a very interesting conversation as well.
Yeah. And having if you need to, bringing a letter from the doctor to talk about what migraine is and how it affects you and what kind of support you need from your employer, to be able to be as effective, if not more effective, than everyone else. Right. And I think that's reasonable. And the challenge with these is that you can have a great company culture, or you can have a horrible company culture. But if you've got a great boss, if you've got an amazing boss that understands, maybe their partner or they have migraine themselves, then that's wonderful. Like, you can tell them and you can have, that support and you can still succeed. And the opposite's also true. You could have an amazing culture, but a horrible boss. And despite the support that is touted by other parts of the business or the organization, you may still feel uncomfortable sort of disclosing to your manager. And so there's options there as well, like, maybe speaking to HR or seeking help from sort of an ally that you may have within the organization about how to broach that conversation, because the relationships with your manager and with your immediate team are paramount in your success at that organization. And so that always has to be factored into your decision as to whether you disclose or not.
Yeah. One person in the chat actually said last night that in the case of if you've got unsupportive wider workplace but a great boss, she said that she's asked her manager to say to the team in like a weekly meeting or something to bring it up, so that then she doesn't have like the burden of having to approach her like everyone in the business directly. It's like something that the manager can kind of take that off her shoulders, which I thought was a good piece of advice in the chat. Right, should we move on to some of the questions coming through on the Q&A now?
Yeah.
Or was there anything else you want to highlight?
No, I think that's good. Like we can jump to questions.
Great. So Teresa had a question, which I think is very important, about how Jacinta said that triptans should be taken at the end of the aura and at the beginning of the headache phase. But that's actually contrary to what Teresa has been told about triptans and how they've worked for other people. So what do you have any information about that on like the timing of taking triptans?
Oh, yeah, this is a good question. I don't want to steer people the wrong way, because I've heard both. So I've heard that, because I have migraine with aura, and the theory was that because triptans can be vasoconstrictive and aura may also be vasoconstrictive, it may be better not to take triptans until after the aura has passed and then the headache is beginning to set in. But I've also heard that that actually no, that's not necessarily the case. So I think, like, without steering people, I want to double check that and get back to people. But yeah, my gut feeling is that it's okay to take the triptan at the start of the aura. But the reason why you want to take the triptan before you sort of start experiencing pain is because triptans still take 20 to 30 minutes to take effect. So if you can do that, like if you can take a triptan 20 to 30 minutes before you have the head pain, you're kind of lining it up optimally for interrupting the attack. So that's what I would aim to do, regardless of whether you have aura or not. But I do want to just make sure that that's factually correct. So Teresa, let us get back to you on that.
One thing that I will say, I don't know if this applies for all triptans, but in our article about sumatriptan, we had initially written before the medical review, take it at the start of the headache phase, and the medical reviewer actually changed that part to say, take the triptan when you take sumatriptan when you start to experience head pain or your most bothersome symptom. So I think we'd have to ask the medical reviewer to elaborate further on that. But yeah, there obviously is kind of something there about the variation in how it works for people. So we've got a question here from Perry Lee Sandel about has anyone had success using a Cephally machine as a preventive, using it daily? She has one, but she hasn't been committed to it. Carl, have you heard anything or tried anything with Cephally?
Yeah, so I've tried Cephally myself years ago. It was an earlier version of the device that exists today. I think the device is something like 3 generations ahead of what I had, and has gotten a lot better as well. And Cephally has some good research actually to support its efficacy and its safety. There's a very small percentage of people that don't respond well to neuromodulation, and neuromodulation itself sounds kind of scary, but it's basically sort of a little bit of stimulation around the device in the middle of the forehead here. And what it does is help raise your threshold for migraine. And doing that on a regular basis, and even during migraine can help, for evidence is shown. So I would say it is worth exploring. It's another option. The fact that you don't need to take an oral medication for it, that you can put it on, then it's another great option to have in our toolkit, and certainly one that should be considered.
Yeah, no, that's definitely great advice. advice. We have another question here from Valerie about triptans, saying, do you know if triptans work for vestibular migraine, where vertigo is the initial onset symptom for 2 weeks with the headache in week 3? Do you know anything about that, or is that kind of a bit beyond our scope? Just, is that something that needs a doctor's input?
I've spoken to experts about vestibular migraine, and what they've told me is that a lot of the treatments for vestibular migraine, which is where you have vertigo and dizziness, and that can be the most bothersome symptom, actually. It can be more debilitating than the head pain for those patients. But a lot of the treatments for that type of migraine are the same as the treatments that people have for migraine itself. There's not like a subspecialty or a subset of treatment that's designed specifically for vestibular migraine, except for some of the vestibular rehabilitation therapy, which is almost like a physical therapy to adjust and recalibrate the vestibular system. And so there is an expert in this area. There's several actually that come to mind, but one is Xin Be. I'll put his name in the chat here. It's worth looking him up. I'll just put vestibular migraine expert. He sort of specializes in migraine and vestibular migraine specifically. He's written a book with the Dizzy Cook, who's an advocate who has vestibular migraine, and they've got, I think, like recipes and stuff like that. But he also does vestibular rehabilitation. So it is worth looking into that. But to answer the question about the triptans, you treat them the same as you do for a regular migraine attack. So if you had a regular migraine attack that lasted 2 weeks and then there was worse or other symptoms in week 3, can you use triptans throughout the whole time? I probably wouldn't. That's probably where you're thinking about prevention as much as you can. If you have a 2-week or 3-week attack, like you really want to be doubling down on the prevention, and you'll still take acute treatments, but you'll need to be kind of strategic in how you do it, because you won't be able to take a triptan every day of the migraine attack when it lasts that long.
Yeah, definitely.
Yeah, and I just saw that Valerie responded and said that she has tried the rehab and several medications. I would look at what is coming out from Shinbe and other vestibular migraine specialists. Another one is an ENT otolaryngologist, Dr. Rick Godley. And there's a couple of others as well. Michael Texedo is another expert in vestibular migraine. Look at the type of therapies they do. Look at the combinations of treatments as well. Often, one piece of advice that I was given that kind of led me astray was just to try one thing at a time. And that makes sense when a doctor is talking about a specific treatment and they want to see if that treatment works for you and not interact with other treatments. That totally makes sense. But the way that I took it was, all right, I'll try this treatment and then everything else will just keep the same, because that way I'll know if it works. But actually what I encourage people to do is all the behavioral and lifestyle stuff, like addressing your sleep, getting tested for sleep apnea, taking magnesium and supplements like CoQ10 and maybe riboflavin or feverfew, which have been which seem to be helpful. Using devices, all these things can work synergistically. And I would be transparent with your doctor. Talk to your pharmacist as well about any medicinal or supplements that you might be taking, vitamins as well. But I try to do everything all at once. And then if you get better, fantastic, right? If you reduce your migraines by half, brilliant. Do that for 3 months, get in a good place, and then you can start to peel back things and find out what works, what's working for you and what's not. So for example, like when I was doing that with supplements, I was taking all these supplements. And I was doing a bunch of other things as well, like regular movement, meditation, relaxation, device. I was using the Cephaly, and I was taking medications, preventive as well as acute. I was doing all those different things, and I was spending a fortune. And then as I was getting better, I started to peel back on one thing at a time. And that's where I was sort of tracking by keeping a diary and sort of looking at what worked for me. And some of the first things I took away were the most expensive supplements. And for
Yeah.
me, right, everyone's different. Everyone's different. Like, everyone's nutritional profile, everyone's diet, all those factors are different. But for me, I was able to take back all of my supplements except for magnesium. Magnesium for me is the only supplement I still take daily and have been taking daily for years. But the other ones I didn't notice any benefit for. Now I know people that benefit from other supplements and they don't need to take magnesium. So that's why I think it's worth testing for each individual, um, and um, and sort of peeling away sort of that way and doing everything you can to get better. And know that,
Mm,
if you do this for 3 months and you get better, that's fantastic. And then you can rebuild your threshold. You can get a bit more stability. You don't feel as vulnerable, and then you can start to live again, right? You don't have to go to bed and get 8 or 9 hours sleep every night. Once you get back to episodic migraine, you can start to make judgment calls and be quite dynamic and decide, okay, you know what, this is a wedding. She's my best friend or he's my best friend. I'm gonna sort of let my hair out, for this,
mm,
and you can enjoy life. But there was a period of time where I was very, very disciplined for a couple of months. I kept a daily diary and I tried to do everything, and I was managing it with medical oversight, and that was a big part of how I was able to sort of turn around.
mm. Yeah, I think one thing as well with supplements, so magnesium, it has been shown to help improve like your sleep quality and how easy it is for you to get to sleep. So that's something, with sleep being such a big migraine trigger for many people, that could be something that's helping. But another thing in terms of the efficacy of supplements and the necessity of talking to your doctor about it. I actually recently was reading an article talking about interactions with supplements, and because they're natural, a lot of people, don't realize that they can have quite dangerous, or not, maybe not dangerous, but troubling interactions with medications. So yeah, it's very important to speak to your doctor about that, and make sure that it's not going to be affecting the effectiveness of any of your medications.
Mm.
There was one question here that I thought was interesting from Adam. Let me just find it. Adam said that he told his neurologist he was looking forward to trying G-pants when they're available. And the neurologist said, oh, they're just the same as all of the current CGRP medications. And he's wondering how to go about educating his neurologist. Do you have any advice on, how to speak to a medical professional about it, to educate them?
Uh, so yeah, carefully. As soon
Yeah.
as soon
Mm,
as like someone comes into the doctor's office and said, "Well, I read on the internet," like a lot of doctors would be like, "Okay."
yeah.
But if you have something printed out and it's like a 1 or 2 pager and it's got sort of medical journal reviews, or you could say that you've been recommended this from, Migraine and Headache Australia, or if there's a sort of authoritative source, that can be helpful. I saw Teresa sort of call out in the comments, change your neurologist. That's also an option, particularly if you're not getting the level of support and if they're not interested in your welfare. Like, there's a few red flags that I would definitely suggest changing neurologists over. But some people don't
Mm,
have that privilege. If you're in regional areas, you may not have accessibility to a neurologist. So it can be sort of tricky, but I would do so in a thoughtful way. Remember that they're seeing maybe 30 or 40 patients a day. And so they need to kind of see the credibility behind what's been brought to them, particularly if they're not headache experts themselves.
mm. Yeah, I've also just sent our doctor's directory in the chat. So if anyone is looking for a new neurologist, that page has basically all neurologists that specialize in treating migraine and headaches. So hopefully that'll be helpful, if
Yeah.
anyone's looking. Yeah.
Yeah, and I'm seeing some questions about like magnesium, like the supplements that I mentioned earlier. Personally, I've been able to sort of drop my dose down to sort of 200 to 400 milligrams a day. Um, the starting doses of magnesium can be high. It can be sort of 800 milligrams a day. The way that you can tell if you're having too much magnesium is that you need to use the bathroom too often. It can cause a little bit a little bit of that. So what you do is you kind of titrate down. So if you find that you're going to the bathroom too often for a number two, then you kind of go back down, you lower your dose, and you find your sort of equilibrium. The other thing about magnesium is that there's lots of options out there, and that it's a little bit of the Wild West when it comes to supplements and vitamins. The migraine care product from Bioceuticals is a high quality product that I have used myself, and I've seen sort of the ingredients. That is good. That is probably one of the better ones in Australia. But it's not a pure magnesium. It's got other supplements and that you may or may not want in that as well. But that can be helpful for people. The brand that I use, I think, is called Doctor's Best, and I sort of order it online to be fully transparent. And it's a chelated form of magnesium. It's called magnesium glycinate, which is a chelated form. Yeah, thank you. Anik just posted the Bioceuticals migraine care product that exists. I don't have any relationship with them. I should just disclose that. It's just trying to be helpful for people here that are asking. But I hope that helps.
Yeah. There are a couple of questions here about triptans that are a bit more complicated from Patrick about the specific biomarkers and how triptans affect your blood vessels. Carl, are you familiar with any of that? I personally, that's a bit beyond my expertise, or I guess lack of expertise. But do you know anything about?
Well, what I can say is that the CGRP monoclonal antibodies do target a specific peptide in the body, which is CGRP, like the calcitonin gene-related peptide. The triptans don't target the CGRP in the same specific way. So a monoclonal antibody, an antibody is something that mops up these peptides in the body. And monoclonal means it sort of chases after just those. It doesn't go after anything else. So it's very specific. Triptans do act on CGRP. I'm not a sort of medical scientist, and nothing that we've said here should be considered medical advice. You definitely want to speak to your doctors. I should put that disclaimer out there. But it does have sort of peripheral side effects, and one of those is on constriction. And we saw, I think it was Dr. Jacinta Johnson have that sort of slide where she showed how the blood vessels are affected by triptans in that way. So that is something just to be aware of. Catacil, Patrick, is, I can see here that's a study that you mentioned and is something that you have. It's something that I would say, you need to speak to your doctor about, because it is sort of a subset. And if it is related to hemiplegic migraine, then you definitely want to be cautious. I know that triptans are not necessarily prescribed to people with hemiplegic migraine because they can be contraindicated. So yeah, that I would definitely be sort of speaking to your doctor about.
Yeah. Are there any other questions or comments here that you'd like to respond to, or is there anything else, any burning questions that anyone's been sitting on? If you want to put it in the chat now before we wrap up, or are we ready to sign off and close out Migraine Headache Awareness Week?
I'll answer just one more question from David about the PFO, so the hole in the heart, patent fulminovalli. So this is something that particularly people with migraine with aura have that has been noted. PFOs are actually quite common in the population. Something like, it's a meaningful percentage. I think it's like maybe as common as 30% of everyone. So a lot of people that have migraine have PFO. A lot of people that don't have migraine have PFO. Is there a link with migraine and PFO? Could there be a link with migraine with aura? I actually went and got myself checked for PFO at one stage for my migraine with aura. I actually don't have a PFO, which was interesting. And the test I did was like a cardiogram, so they look at your heart. But there is some clinical trials going on about this. I would say that there is an operation where you can do like a PFO closure, and it's mixed results at the moment as to whether we can conclusively say that helps with migraine with aura or not. Heart surgery, you might consider to be a pretty extreme measure to take for something that may or may not help. So I would say, and sort of typically what we say with these things where there's not evidence is that, you could explore doing that, but probably do so in the setting of a clinical trial if there is one in Australia, which I'm not sure that there is. There are in the US, but there's not here. Or wait for the studies and the research to come out and wait for the evidence to be sort of either supported or disproved. That would be my encouragement there. But I know that we're at the top of the hour. Thank you so much for your questions. It's been a great chat. I really enjoyed the less formal sort of interactions that we've had today. Thank you so much, and Anik, thank you as well for helping facilitate today.
Yeah, no, thank you so much, Carl. It was great to come on and chat to everyone, and yeah, it was a great way to close out a fantastic week. A lot learned and lots more to learn in the future, I guess.
It's been an incredible week. If you still haven't had your questions answered, we'd encourage you to email us. You can do so through the website. There's a contact us page. We'd be happy to sort of dig up some answers or at least point you in the right direction. But thank you so much for everyone for joining us. We really appreciate your attendance and support throughout the week. And we hope you found some answers that can help you turn the corner in your own headache or migraine condition. That brings us to a close. So thank you very much. And we'll be in touch soon.
Yeah.
Bye-bye for now.
Bye.